Okay, I'm ready.
Okay, so if you've read and understood, considering its surgical pathology station, please tell me what do you understand by the term signet cell carcinoma?
Okay, it is a special type of gastric adenocarcinoma that is
Yes.
very aggressive, that has a characteristic presence of a signet ring cell under the microscope, and it arises from the glands that produce the mucus.
Okay, what are the most common or what are the different types of carcinoma of the stomach?
Okay, we have adenocarcinoma, this is the most common one, and we have maltoma, which is a mucosa-associated lymphoid tumor, and we have neuroendocrine tumors like carcinoid tumor. And we have rarely we see a squamous carcinoma of the stomach.
Okay, is there any classification by which you can divide different types of carcinomas?
Yes, we have a WHO classification, and we have a Borman classification, and we have Lorin classification.
Okay, please tell me about it.
Okay, the WHO classification depends on histology. We have tubular adenocarcinoma, and we have papillary carcinoma, and we have mucin adenocarcinoma, and we have mixed adenocarcinoma, and we have poorly cohesive adenocarcinoma. While the Lorin classification classify the gastric cancer into diffuse gastric carcinoma and intestinal gastric carcinoma. The diffuse gastric carcinoma is most common in the young age. Has poor prognosis and poorly differentiated and has high potential to metastasize. While the intestinal type affects the elderly age and good prognosis and good prognosis and well differentiated and has low potential to metastasize. And we have Lorin classification, Borman classification, which classifies them according to macroscopically to well circumscribed polypoid and fungating polypoid, and we have Linatis
Ulcerative.
plastica
Okay.
and ulcerating type.
With infiltrative margins. All right. Okay. And then there is another type, which is on the basis of the spread through the stomach, which is like advanced, early and advanced. Can you tell me about those?
Uh,
Okay.
other classification?
Yes, this is another one. All right. Okay. Please tell me about the pathogenesis of the gastric carcinoma. How does it take place?
Okay, there would be chronic inflammation or chronic irritation due to infection or other factors, which will lead to tissues that undergo adaptation by metaplasia, which is potentially reversible. If the stress continues, it will develop to dysplasia, which there is a DNA damage, which is unreversible, and it is called carcinoma in situ. Then develop intramucosal gastric carcinoma, then develop to uh,
Invasive.
invasive gastric
All right. Okay.
carcinomas.
Please tell me what are the risk factors for gastric carcinoma?
Okay, it could be due to H. pylori infection and
Okay.
intestine and chronic atrophic gastritis and
Yes.
intestinal metaplasia and pernicious anemia and
Yes.
familial edematous polyposis and gastric polyp more than 2 centimeter and family history and
Yes.
previous gastric surgery.
Right. What are the genes which are involved in gastric carcinoma?
Okay, we have uh, specific gene for diffuse gastric cancer, which is CDH1, which is called E-cadherin. Now there is a tumor suppressor gene like ABC gene or proto-oncogene like KRAS.
Okay. Very good. What I want you to tell me now, right, this patient has already undergone gastrectomy and also splenectomy for 6 weeks ago. So, what should normally be the treatment for gastric carcinoma?
Okay, the treatment for gastric carcinoma after taking full history and examination, and investigation and staging and discussing it with multidisciplinary team. If it is uh, if it is resectable or treatable, I will go with gastrectomy and chemotherapy. And
Yes.
if it is not, and if it is not treatable, I will go with palliative management, including feeding jejunostomy if needed, and including pain management for the patient using opioids, and including palliative chemotherapy, and including palliative management for the ascites if it developed by repeated paracentesis.
Okay. All right. If you could tell me what are the paraneoplastic conditions which are associated with gastric carcinoma?
We have cancerous nigricans and dermatomyositis.
Okay, as part of the treatment of gastric carcinoma, patient develops a condition called dumping syndrome. Can you tell me what do you understand by this term?
Okay, dumping syndrome. It happened after gastrectomy. It is due to loss of reservoir function of the stomach,
Good.
result in rapid transient of osmotically active substance from the gastric content into the duodenum, and may cause dumping syndrome, which divide into early or late. Early
Yes.
dumping syndrome occurs 30 to 60 minutes after the meal due to rapid transient of hyperosmolar substance, which will lead to fluid shift from intravascular space to the lumen of the gastric and the duodenum, and will lead to periodic abdominal pain and abdominal distension and diarrhea and vasomotor symptoms like postural hypotension. Also, we have late dumping syndrome occur 1 to 3 hours after the meal due to rapid transient of carbohydrate from the gastric to the small intestine, with
Yes.
leading to absorption of high level of glucose with compensatory hyperinsulinemia, which will lead
Yes.
to hypoglycemia and causing dumping syndrome.
Okay, good. This same patient, which is in front of you, presents to you. So 10, okay, all right, presents with you after 6 months. And patient has presented with ascites and deranged liver function test. What do you think might have happened to the patient?
I think this could be malignant ascites due to liver metastasis of the gastric cancer.
All right, good. What would you do then? Which test can you do? Which two tests?
Okay, I can go with paracentesis, acetic tap, and for acetic tap for cytology, biochemistry, and cytogenetic and others. And I
Okay.
will go for liver biopsy, and I
Right.
can go for left supraclavicular lymph node biopsy or tumor markers for recurrent, especially CA 72-4.
All right. And what treatment can you offer to this patient at that time?
Okay, I can first for this malignant ascites, I should treat the underlying cause either by surgery, chemo, or radio. I will go with repeated paracentesis if it is for palliation, or
Yes.
hyperthermic intraperitoneal chemotherapy,
Yes.
or cell-free or autologous concentrated ascites, uh, cell-free concentrated ascites reinfusion therapy, and I can go with the peritoneal venous shunt for the management of these ascites.
All right. Along with the pain relief and tapping.
Okay.
Good. Good. Can you please describe the image you are looking at?
Okay. This is scattered appearance of cells. It show vacuoles filled with mucins that push the nucleus away, resembling signet rings of.
Very good. Thank you.